Hello, everyone, and welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. This is Aaron Fritts as your host this week, and I'm very excited to introduce our special guest today, good friend, Dr. Chris Beck. Welcome, Chris, and congratulations on the birth of your beautiful daughter.
Thank you. I don't know about special guest. I feel like just like routine guest feels more appropriate, but I do feel a little bit more special coming on as a father.
It's special to have our host as guest.
Okay, that's fair.
So today, I thought it'd be fun to talk about Mediport placement, since you and I love to talk about these kind of low-hanging fruit topics that are high volume, definitely bread and butter cases for the interventional radiologist, and something that even as a resident got to do a lot of. I remember I was lucky in that the community hospital where I did a lot of my IR rotations at, the IR guys there those who were interested let us do a good amount of Mediports. And so I always found, it's a great kind of starter case other than, PICC lines. But a great, basically venous access case to start with. You learn how to do a cut down and, create a space. And so I wanted to go over basically, for the uninitiated, maybe for trainees out there, but also, young IRs out there who might learn something, a new trick, and also a little bit of discussion about, how we do things differently, right? Because everybody does things differently. Some people like to throw their Mediports in really fast, and others like to take more time. And we can kind of talk about the pros and cons of those different approaches. So, Chris, you want to start with kind of talking about, in your practice, what are the most common indications, why you get these Mediports, where they come from?
Yes. So by far and away, most common indication is malignancy. And so we're putting these in for long-term venous access for chemotherapy. By far and away, that's like the large majority of our cases. Every now and then we'll get a sickle cell patient, but for 99.9%, it's all onc patients.
Okay. Yeah. I mean, I guess the other cases are people who, for whatever reason, are hard sticks. People are getting, frequent blood transfusions, anemic patients, stuff like that. But yeah, you're right. For the most part, it's for malignancy. Any contraindications to getting a Mediport place where you might say, this patient should probably get a PICC line or some other kind of access before a Mediport?
Yeah, for me, the most common contraindication that comes up in my practice is if I suspect there's a current infection. So if for some reason they present as an outpatient and for whatever reason they describe an active infection, or they're on antibiotics currently, or they've just started on a round of antibiotics, if they can wait, I'll reschedule them. If not, if they have chemotherapy happening that afternoon or later that week, then I'll place a PICC, let them finish out their antibiotic regimen, and then bring them back and put in the port. I've seen some other, I don't know if they're contraindications, but it certainly makes life a little bit more difficult, is if someone's had there's no place to put the port. I think maybe you've probably seen some patients who have terrible radiation burns to their chest, and so you have to get a little bit more creative about where you put the port. That can come up. Mastectomy patients, although I still think it's reasonable to find an area to put the port, but that can present a challenge. And then as far as, I think one of the things that gets put in for anticoagulation is bleeding diastasis, but I've never not put in a port because I was worried that they were going to bleed out after or during the port. I don't know about you.
Yeah. The Coags, I mean, I definitely like them to be off of, I follow SIR anticoagulation guidelines, but, we'd standard would be to check the INR, and, PTT. Ideally INR is less than, 2.0 for me. Because what I've seen happen before, this actually happened in fellowship, is, coagulate, somebody's on Plavix and aspirin, and you put the port in, and they come back with a hematoma in the port pocket, And I've seen that happen, and it can, it can get messy, where then you're like, the patient comes back, they get a big Goomba over their chest, and, you're like, okay, what do we do now? Do we take this port out, or we try and get this hematoma to settle down? And that hematoma can get infected. So I'm kind of fortunate. I saw that early on in fellowship, and so since then I've been pretty strict about the, at least making sure that they're off anti-coags ahead of time, and also just checking the coags.
So do you routinely check coags before all ports? Okay. Yeah. See, that's maybe where I differ. I stopped checking coags with port placements, and unless they have a history of being on something that I think they're going to, if they have, if they're on Coumadin for whatever reason and they haven't held it, or if they've only held it for one day, then yeah, of course I'll check it. If I have any reason to think that they're going to be coagulopathic, but otherwise routine patient, routine onc, I'm just going to push ahead without knowing the INR or the PT.
Yeah. Yeah. And, like you said, I mean, some of these, they're cancer patients, so they can have coagulopathies. So granted, those are more thrombogenic, but coagulopathies, but still, I like to get an idea, just a baseline. And it's, they're already getting usually lab work, when they come in, a CBC and BMP, as part of the outpatient workup at these hospitals I'm working at. So, it's usually just part of it. And I definitely check before, I go into do the procedure. Sure. And then just to take a step back, because you mentioned something about putting a PICC line in, and I know that you put in arm ports. Have you ever had that in mind when you put a PICC line in, that you already have access, and maybe get access a little bit higher where you would put an arm port and just do a transfer from a PICC to an arm port?
So I've never done that. And I don't even know if it would be a consideration of mine. One, I've never converted a PICC to an arm port. And a large majority of the ports I put in are just conventional chest wall ports. It's only every now and then if a patient has either it's patient preference, for some reason they know about an arm port and they think that would be more comfortable for them, or they have some kind of, sometimes mastectomy patients would prefer that, or sometimes there's radiation burns to the chest. So the arm port is really still an outlier for me. And if I am putting in a PICC, I'd probably just still then go and convert it to a chest wall port. But let's just say there was the theory that I'm putting in a PICC and then I'm later going to convert it to an arm port. It's still very, I don't even know if I'd go through the bother of keeping that venous access. I would probably just take out the PICC and then just restick somewhere else. Rather than trying to make my PICC placement different than what I normally do.
Yeah. And that's a good segue into, kind of choosing a side and location. You want to just talk through for the uninitiated, why we generally go on the rights, what vessel we're accessing?
So I'm right IJ, right IJ, right IJ until I have to go on the left. That's how I feel about it. So I really like going on the right. It's a shorter distance, your catheter distance will be shorter because you're going from right IJ to brachiocephalic to SVC. It's just a longer distance to go from the left. I don't know how else to explain it better for the trainees, but as you start to put in more and more catheters, I'm not saying it's a big hurdle to overcome, because certainly it's surmountable, but right IJ makes everything easier.
Yeah, recently I had a case where I had a Mediport on my schedule. I go up to the lab, typical day, kind of busy running around. Okay, nice Mediport, think it's going to, Tipshot case. I come in, I talked to the patient. They had already prepped the patient out because they were waiting. And so I'm talking to them under the drape, and I'm talking about, hey, what kind of cancer do you have? Oh, it's breast cancer. Okay, where's it at? Oh, it's on the right side. Okay, where on the right side? Oh, just
upper outer quadrant, just under my clavicle.
Yeah, exactly. Right. Yeah, right where I'm going to put the Mediport. And I was like, okay, well, this isn't going to work, guys. And so after that happened, and this is at a lab that I'm not at very frequently, but I'd say, look, I got to talk to these patients before you prep them out, or you guys have to ask, hey, where's your cancer at? how are you being treated? I think it's very important to talk to the patient beforehand and be clear about what they're being treated for, where that treatment is. She was going to undergo a lumpectomy and radiation, shortly thereafter. And so I was like, well, I'm not putting a port right in that area, and so you have to be careful about that. And of course, and then I had to go on the left.
Yeah. And I think it's still fine to go on the left, but like if you're going to have, like if you have a patient with breast cancer on the, the right side, then, and that they're going to get radiation or mastectomy. A lot of them, by the time they get to me, have already had the mastectomy. And then lung cancer, like high lung cancers, like at the, like at, towards the apex, you want to avoid there because it may end up in the radiation field. And I'm trying to think of what else, like it seems like lung cancer and breast cancer are the ones that routinely come up for me. Another reason that I like going right side, and I don't know if you have this issue, or it's kind of a non-issue, and it seems like small to complain about it, but whenever I tunnel, I'm more comfortable tunneling with my right arm. And so, so like tunneling on the left side, you're using your left hand, which is still very doable, but everything for me is just more comfortable on the right.
Yeah, it's tricky. And then the other thing is, and we're going to get into technique in a sec, but I just want to talk about limitations of left-sided ports for a sec, is once you get your wire down and you get that peel away sheath down, depending on the length, sometimes it could be a little bit short, right? And so when you go to put your catheter down, it might pop into the azygos, right?
For sure.
And then it can be really hard to get out, or it just doesn't quite make the length, or I've even seen them pop up into the the right brachiocephalic, right? Right brachiocephalic vein. So those are things that kind of are annoying about going from the left. And so, but anything else on that note before we jump into? We were kind of talking about arm ports. We can let's just walk through a standard placement.
Yeah, sure. I actually wrote some notes on standard placement just so I didn't leave anything out. So for me, I try and do the same thing every single time. So like we can just pretend it's a right IJ port, although I don't know if the steps are any different for my left side. So right chest wall port. So I always use ultrasound guidance to access the IJ. If for some reason the IJ is out, I don't have a problem doing an EJ. That would be a little unusual with oncology patients, but it can happen. So lido, and I lay down a lot of lidocaine. I don't know about you, but I am not shy about putting in like a lot of lidocaine. Like that's one of my pet peeves when we don't have enough lidocaine on the table. I like a lot of lidocaine for ports. So a lot of lidocaine, dermatotomy with the 11 blade, IJ access with a micropuncture. One of the things I do for for access in the vein, and this was a Vanderbilt thing that someone showed me, I think it was from Bream, is that he always coaxed me to bring the vein to the far end of the ultrasound image. So that way you had a really short throw. Whenever you think of the picture, you think of the vein right in the middle, but I access in the transverse plane. So where I see the whole needle along the length, but I just bring the needle to the very edge. So if you're looking at the ultrasound screen, to the left edge. So it's a real short throw. And I don't know what that really does other than that, it just creates less skin and everything to tunnel through, or to
it's less tissue to tunnel through. I mean, and sometimes if they've had any kind of line before, there's a lot of scar there. And just to step back to the lidocaine thing, I mean, 9 times out of 10, when patient's going to hurt during a Mediport placement, it's when you're putting that sheath, when you're dilating and putting that sheath in at the dermatotomy site. That's where they hurt. They don't even hurt really when you're putting when you're creating the pocket. But yeah, so I think it's, like you said, it's important to put a lot of lidocaine down there. And it's funny, the whole, I do it subconsciously as well. And I guess maybe that's where I got it, maybe from Bream as well, as with the whole getting that, that vein right on the edge of the ultrasound screen so that you're popping right down into it and not having this big long needle track.
You don't want to create a long throw. And plus it also, on the back end, for whatever reason, I feel like it creates a nice curve whenever you do a nice short access. But yeah, I feel like Bream must have beat it into us because that's where I get it.
And nice and low.
Oh,
right
yeah, access.
Not
no. That's that's amateur hour, man. I I also read diagnostics, and whenever I read like, you know, port placement, and then I see like they access, like, looks like they access someone like near the mandible, it's just like makes you cringe. But yeah, so like right above the clavicle and then angled down. I mean, a friend of mine jokes that he angles at the confluence of like the subclavian and the IJ, but yeah, I'm all about a low IJ stick. Yeah. So all right, so access micropuncture set. I will do an intravascular measurement. I don't know if you do this, but I basically have the wire, the micropuncture sheath in, and then I put the wire exactly where I want it, like where I want to land my port catheter, and then I pull that wire back and create like an intravascular measurement. Does that make sense?
Yeah. So, and I think I don't know if that was a Vanderbilt thing too, but I learned Jim McElmurray taught me that technique where to basically measure the wire, and then you use that to measure your catheter. I'm gonna tell you about something I picked up later that's a little bit different where I stopped doing that. But yeah, I used to do that for a long time.
I mean, so I just use the wire to like measure the intravascular length every now and then. Like like sometimes I forget, and then I don't have any problem laying the port down on somebody just to like give yourself an estimate, you know. And then you just have like the port external to the patient, and you just put it over where you want, and then I'll snip there. But a lot of times I just do an intravascular measurement. If I am measuring from the left, like, and I have like that intravascular measurement, I usually add 2 centimeters for like a fudge factor. I've just found that like adding those. Whenever I think about like ports that you have to revise, like I can think of a lot of ports that I've revised because they were too short. I just can't think of any that I've ever revised because they were too long. Yeah. So, all right. So I've got that little wire measurement, so I know my intravascular length. Then I'll take that wire out, and so it's on the back table, and you know I got like a little measurement tool. And then I'll go from micropuncture sheath with like a Rosen or a Benson wire, whatever basically is on the field. And then always put that in the IVC. Once I put that in the IVC, I'll take a picture. That's also something that's kind of beat into me. Every time I take a picture, and it's just to prove that you're venous in positioning. Yeah.
Right.
So once I'm there, I've got the wire in. Sometimes I'll put like a little cap on it, like a flow switch, but a lot of times the wire will keep it from back bleeding. And so then I just move on to pocket creation. So I usually do about 2 or 3 finger breaths below the clavicle. Oh, were you going to?
So wait, back up for a sec. Do you put the sheath in first, or what do you have in while you're making the port?
Oh, so I don't put the sheath in usually. Like I'll keep that micropuncture.
The peel away.
Yeah.
Okay. So just, and I'm just going to compare to the way I do it. You just keep the micropuncture in with the wire in, or do you put a syringe on the back of the micropuncture?
The micropuncture with the wire in.
So you keep the wire in while you're doing your port, while you're doing your pocket.
What do you do?
So that having the wire in always made me nervous. That like they're going to take a big inhalation and the wire's going to suck right in, or the wire's going to touch something. So I always get the wire out, and I used to put a little syringe on the back, but then sometimes that micropuncture would get kind of jammed up when I was trying to tunnel. So then what I'd start doing is I would just get my wire down, and I would just dilate, put my peel away in, and take the dilator of the peel away out, and because the peel away has a sheath, right? It's a valve sheath, or sorry, the peel away has a valve.
The peel away's got a valve on it,
and so I just have the peel away sheath in the IJ, and then I make my pocket.
I think that's fine too. I mean, I don't see any problem with that. Yeah. For whatever reason, I think I just do this the same way.
Yeah, it's just because that's the way you're saying. I mean, I've kind of changed it up, and I just feel like then I know I have access, and it's just, and it's already dilated and everything.
You don't worry about them like taking a big breath in and then all of a sudden sucking through that peel away?
The valve is there.
I don't know, but is it like, I've
never had
100% that valve?
Yeah, but it's not the same as like a dialysis peel away. It's smaller. It's what, 8 French, 9 French?
Actually, I don't even know what the size of it is, but it must be at least 8 French, right?
Yeah, I think it's a 9. So anyway, that just a small difference, yeah. There's no better way. It's just the way I do it.
I agree. So at this point, so I have wire in and the micropuncture outer sheath in, and so then I do the pocket creation. The only thing I'll say a couple things about the pocket. So I usually try and stay like 2 finger breadths below the clavicle. I make sure that the incision that I make, so it's not with the 11 blade. I'll usually have a 15 blade on the table. I try and make like one. I try and know how big the port reservoir is, so I'll have an idea of what we're putting in ahead of time. And I don't actually mark it out, but I just kind of make a mental note, like how much, cut, like, because I don't like the incision to be so large that, it leaves me more time to sew up on the back end. But I want it nice and snug, but also like, you got to have it big enough to where the reservoir will actually go through it. And I like to make one cut. And so it's like one firm cut. I remember whenever I was in training, I was a little bit ginger about making that first incision. You wouldn't take it all the way through the sub-Q layer. And then once I've made that one cut, I just dissect straight down to the chest wall. And then once I dissect down, I'll just find a plane with my finger. And then everything else I do is blunt dissection with my finger. And so if I run into like a little sinew, I'll just pop it with my finger. And then I just kind of push inferiorly along the chest wall. And I try and keep my port pockets pretty tight. I'm sure we'll mention like whether or not we sew down or suture in the port, but I like to have like a real tight port pocket in basically the lateral and medial dimension. Like I don't like there can be a little play up and down, but I do like the port pocket to be pretty tight around the reservoir. Anything to comment about the port pocket? Because I feel like that's a thing in of itself.
Yeah, I'm a minimalist when it comes to the incision, so I try and I would say my incisions are about 1.5 inches, just under 2 maybe inches in length, and then that way and we'll talk about which ports we like and for what reasons, but and I'll test it. I'll take the port and I'll keep trying to see if I can fit it in there because I want a nice snug pocket, and that's why I don't tie them down. It's because I create a nice snug pocket so that they're not flipping around in there. But yeah, that's pretty much the same way to do it. Lots of lido. Obviously, you don't want the patient to be feeling that. They might feel that blunt dissection, but that's why, like you said, pump lots of lido in there. But that's pretty much it.
And actually that's one of the ways, ports are something like you do so frequently that there's some ways to like save yourself some time. And one of the things I'll do whenever I'm anesthetizing the chest wall for the port is I'll make a little skin wheel. So like a linear skin wheel. So I have an idea of how long I want my incision to be. And then also I'm using, I don't know if you do this. I feel like this was a trick like Chris Barron from Vanderbilt taught me. I use my micropuncture needle to do the anesthetizing. So one, you can get more lidocaine in there and quicker rather than using like a 25 gauge needle. And also so I'll take that micropuncture needle and I'll just have one stick site where I'm putting all the lidocaine, and I use that stick site to do where my incision's going to be. I'll turn it inferiorly and direct it to where it's going to catch the port pocket. And then I turn it superiorly, so all in the same needle and all the same stick, and then I turn it superiorly and I'll put it all the way up by the clavicle, and then I'll lay lidocaine all along that track where I'm going to be tunneling. And it's just right. To me that's just one way you can save yourself. It's just kind of an economy of movement to where you can save yourself a little bit of time rather than sticking the patient in 4 different spots and putting down lidocaine. Yeah,
definitely minimizing sticks. Keeping it superficial so it's just under the skin along where your tunnel's going to be.
One more thing I'll say about the pocket is I definitely, even though I like a snug pocket, I do like the pocket to go inferiorly enough. I don't like, in the end, I like the incision to fall right over the port reservoir cap, where the catheter meets the reservoir. What I do not like, and this is just me, I don't know if there's any data behind this, but I don't like the incision to fall on top of the port reservoir. Do you know what I mean? It creates more tension there than I want. So I tuck that port reservoir where it's well below my incision, and that way the incisions can, or at least in my opinion, can remain a little bit less tension on it because there's not a bulging port reservoir underneath it. So that's one of the things I do with the port pocket.
No, I totally agree. Because when you're stitching, and you'll be able to tell when you're stitching it up at the end, it's how much tension you have, and sometimes you might even have to get in there and create a little bit more space for your port so it sits further back. But like you said, right where that hub is, that's the ideal place for the hub to line up with your incision, so that even when on retrieval, when you're making that incision, it's going over the hub and not over the catheter and not over the port.
Yep,
you know what
agreed.
I mean?
Yeah. So once the port pocket's in, then I will, ideally the tech is like tested and assembled the port and it's on the tunneler. So then I will tuck in the reservoir into the port pocket, and then I'll tunnel towards the neck incision. I try and have the tunneler where it's like perpendicular to the clavicle. I don't even know why I'm kind of a nut about that, other than I'm just a particular guy, and I don't know, maybe it's a better look for the port. I have no idea, but I feel like that's also something Bream told me to do. And ever since, I've just carried that with me. But as I'm saying it out loud, I'm like, I don't know why that's important. So I tunnel with the dial, or the tunneler perpendicular to the clavicle, and then I pop out the other end. Sometimes there can, one of the things I should mention is that, like, once you do your dermatotomy at the skin entry site, like up in the neck, I do dissect down. I dissect down to the vein, and then I turn that dissection back, and I'll direct it towards the clavicle. That I think makes makes the tunneling a little bit easier. I do that for like ports and dialysis caths.
That's a good trick, because a lot of times it's hard to get through that hole, and then I end up taking a blade and trying to find my tunneler almost always. But that might actually help prevent that.
That for sure will help you prevent that. Yeah. Now you still have to like push that dilator around till you find that little cleavage plane, but it makes it a little bit easier. And I can't remember the last time I had to like dissect back or like cut down on it. That's not true. I can remember the last time. It's not that long ago. Still comes up. And so then I tunnel. I pull the catheter kind of taut, and then now the reservoir is just sitting in that port pocket. I know the length of the catheter that's going to be underneath the skin. And, there's a little number where you can tell like how much of the catheter is in the chest wall into the neck. And then, if I can take everyone back to like that intravascular length that I had, so if I have 8 centimeters from the port reservoir to the skin entry site at the neck, and then I'm like, okay, my intravascular length is 20. So then, I have a 28 centimeter port. That's not actually a good number. It's usually like 15. Like I find most ports I cut between 20 and 25.
Okay. Yeah, that's about the same as me. Yeah. 20 to 25 is the magic. That is definitely the magic number.
So, right. There's an expression like measure twice and cut at 23. Yeah.
Right. Yes.
So then you have the port catheter sticking out. I don't take off the dilate, or I don't take off the tunneler. I'll just cut it to the desired length and then chunk that. I used to like put a little, do like a measurement on the external to the patient, just to make sure it like was in the ballpark. But I just gave up on that because I feel like my measurements are more on point than like actually just laying the catheter across and estimating it. So at that point, I only have the micropuncture sheath end. So then dilate, peel away sheath, and then, stuff the catheter, pull the peel away sheath, and then check and see if it's in the right spot.
Yeah. Yeah, the only difference, like I said, I used to measure with a wire, and then I started laying it over because I saw a colleague of mine do it. And I was like, oh, let's try that. And I just started seeing where, we were talking about 20 to 25, and almost always it's like 22 to 23. So I just take some curved hemostats. I narrow my window on fluoro, and I just want to see that tip. I try and align it with where the sheath is, where I can see it. So it's not like an acute angle. So I try and align, and almost always it's like 22, 23, and I just cut it right there. And I knock on wood, I haven't been disappointed yet with the layover approach.
I don't think there's like a right way and a wrong way on that. I think like the layover approach is perfectly fine.
I think it shaved a couple minutes off my.
There's no way it's shaved minutes off the procedure time, but yeah, maybe a little bit. But like, that's the thing about ports. Like, people always talk about speed of ports, and people will tell me, like, even like the people that do ports really quickly, and they'll say they can do a port in 10 minutes. I mean, that's fantastic, but I don't mind taking 15 minutes on a port, or whatever. If I take 20 minutes on a port, my day is not like based off of the 5-minute increments that I can save.
No, I mean by spending the adequate time on a port saves you hours on the back end when they don't come back with their port exposed because you didn't stitch it up properly, or or it's just non-functioning. No, I agree. It's funny because I remember we had like a little competition at Vanderbilt about speediest ports and stuff like that, and it's whatever.
Yeah. We had the same thing in fellowship for some reason. Like we would like try and like who could put in the port the fastest. But and I think there's some value to that. I mean, I think there is, like, I like the economy of motion. Like, I like being very efficient with every movement that I make it very intentional. Everything's got a reason behind it. You cut out all the fluff of the things that you're doing with, like, in terms of like, oh, I now have to dab this little piece of blood off. Like, I like being very efficient with my procedures. Don't get me wrong, but you're
not timing
no.
yourself.
I mean, like that's like things you do when you're younger.
Yeah, and on the other side, you're not taking 2 hours.
Yes, that's right.
More important.
Yeah, no, it doesn't take me all that long to put in the port. And then I guess like closure of ports, I think that can vary a lot between operators, like how you close.
Yeah.
I'm interested to see how you do it, but I will. So I think now at this point, I'll also, one of the things I do is I'll usually test the port before I close it. I think most people do that just to make sure that you have a good functioning port. And so I'll do withdrawal, then I'll flush in, and then I'll usually heparinize it. And then after that, I'll close up. I'll do 3.0 in the deep layer. And then I'll try and bring that pretty close to superficial. And a lot of times, like the way I'll make that throw, I can really like bring some pretty close apposition to like the skin. And then if I can, then I'll just go ahead and glue the skin after I've done like maybe 3 or 4 interrupted 3.0 vicryls. And if I can, then I'll just glue the rest of the incision. And if I can't, I'll do a running 4.0 Ethylon sub-Q layer to close.
Yeah, I do mine the exact same every time. I do 1 3.0 vicryl interrupted to close up the deep layer. And usually by that time, it's so well effaced that I could actually glue if I wanted to. But I still do a running uninterrupted 4.0 to close it, and then I do Dermabond over top. And that, for whatever reason, since the day Jim McElmurray taught me how to do that, that's never changed. I do it the same every time. And then I do a little bit of glue at the top.
Yeah, glue the neck.
Because usually that incision's
not
that's
like
big.
a just tight little incision.
Yeah.
Do you still have Dermabond now? Like, we've moved on to like these generics of Dermabond that are not quite as good as Dermabond, but still work. I mean, still now I just call everything glue.
Yeah, there's something called Liquid Band by McKesson. I have some on my shelf here.
I do Skinafix. Skinafix is what we have.
I stitched my 7-year-old sliced his knee open the other day, and my wife was like, "We gotta take him to the ER for some. She gotta get stitches." And I was like, "Nope." And I grabbed some Dermabond and glued it, and now it looks great.
That's good. It's always nice to have like 1 or 2 Dermabonds laying around.
Yeah,
I think everyone does.
You're right.
So one thing I will say about gluing it up is like whenever I'm gluing it up, I kind of take a little bit of care. I don't like to get glue in the wound. Like, you want to make sure like the skin is opposed. Like, you really are looking for like a tension-free incision. And so I'll make sure the skin is nicely opposed and then glue it up. So I actually take a little bit of care with the incision because, for all we make of like, venous access and our like wire and catheter skills, like I think like when you're going to have problems with the port, a lot of it can come from your incision. So I take a little bit of care with that.
Okay, so we'd already talked about why we don't suture in place.
Did we talk about why we don't suture them in place?
Well, briefly. I mean, you make a snug pocket, I make a snug pocket. I feel like it's not, knock on wood, I've never had a case where a port flipped, and I think that's because I make a snug pocket. Now, people who actually are religious about suturing their ports in place, and I think those are fewer and far between. It's rare to meet somebody who's like, no, I do it every time. I think that they're making a huge pocket. Just having seen some of those people, creating their ports or their pockets. Now, for me, it saves time on the back end when you're going to retrieve that port, and you don't have to search for the sutures. For somebody's putting like Proline in. There was a time when I wasn't using the clear views. The clear view is a silicone body, so you can stitch it from anywhere.
Oh, nice! So you can just grab a hold of it.
You can just grab a hold of it. You don't have little holes, right? But occasionally I'll put a port in, like an angiodynamics port or a different type of port, and it'll have those little holes. And so I would do sometimes, especially if it was like somebody with like large body habitus, for example, and you are a little bit afraid of, maybe that port flipping, if you're just placing it in subcutaneous tissue, because they have so much subcutaneous tissue, fat, that you can't really get down to the muscle layer. So you want it to be superficial enough where people can access it. And that's when it's prone to flip, right? When it's just kind of floating in subcutaneous fat. So in those cases, what I'll do is I'll try and put a stitch in, but I would use Vicryl so it's absorbable. And what happens over time is the body will form like its own little sutures. It'll scar into those holes. And you'll see that when you retrieve them, right? You'll see like little like, pieces of scar tissue that kind of fold into those holes, and that's the body holding on to it. And so I was doing absorbable suture for a little while, especially for those, I still do, for those patients who I feel like they are prone for flipping, and that's, I don't know, but that's also like once in a blue moon. Otherwise, I'm making a nice snug, pocket, and that's it. What about you?
Nice snug pocket, and that's it. Knock on wood, I haven't had any ports flip, and, I have to say that I know of. I mean, maybe they're going to outside institutions to get them fixed, but I don't know of any ports that have flipped that I've put in, and, until I find a couple, I'm probably just going to continue to push on, carry on, keep calm. I will say something like body habitus did remind me. I think like whenever you put these ports in on like someone like with a large body habitus, like that's something to keep in mind as far as like where you land your port. Like I think I said earlier in the podcast that I think most people you've probably exchanged, or some people do fibrin sheath strippings. Like it's more common in people who leave their ports too short than too long. And then I think it's something to remember that when you're doing a patient who's like supine, that's very different from like a patient who's like sitting up, and then all that soft tissue on the chest can pull everything inferiorly and then shorten up your port.
Yeah, that's true. Yeah, that's a good point. So just real quick on,
is there any worthwhile mentioning subclavian ports? I
mean, just don't do it. Public service announcement. Don't put them in.
I think it's worth mentioning, like, if you are putting in subclavian ports, that's only good for like foreign body retrievals and port revisions, as far as I can tell.
To keep up your practice.
That's right. That's the only thing I've known them to do. I mean, actually, I'm sure a lot of them work fine for a large majority of the time, but we do port checks, and I've seen plenty of ports that fracture at the clavicle, the clavicle rib junction, and then I've done a couple foreign body retrievals for fractured ports.
Yeah, I mean, I've never needed to put a subclavian in. I've never had a mentor or colleague or anybody I've ever seen put a subclavian in. That being said, I mean, not to knock our surgery colleagues, but sometimes that's just how they train.
For sure.
And, but for us, we don't see those complications when we put them in via the IJ. We don't see them kink. We don't see, them, clot as frequently. So that's why we don't do it that way. Real quick, I mentioned the barred clear view. That's probably my preferred port because of the design allows for a tighter pocket. It's kind of like an arrowhead look to it. So it kind of, it's not purely round. So when you're putting it into your pocket, it kind of just nicely will, that triangular shape kind of allows it to kind of fit in there nicely. And then the silicone body is nice because you can suture from wherever on the body. And and also, it just, people seem to be more comfortable with them.
Really?
For whatever reason. Yeah, I've gotten that feedback from patients. They're like, when I take them out, I was like, how did you like that port? And they're like, oh yeah, just, I could always feel it. Never had any issues with it. So just the feedback I've gotten from patients has been positive. So yeah, any ports in particular that you like?
I'll basically take whatever we happen to have on the shelf. I'm not particular about it. The Clearview is a nice port. Yeah. Every now and then, if it's a cachectic patient or I am putting in an arm port, I'll use some low profile version of a port that I think is nice to have for those cachectic patients, or if you're putting in like maybe a non-conventional location.
Yeah, low profiles are definitely great for skinny, and they're easy to put in, and patients rarely have issues with them. I feel like. Okay, let me see.
Do you ever do anything like I remember for a little while there was a little bit of discussion whether the three little palpable markers that like go on the basically in a triangular fashion around it. People were shaving those off, I think, or maybe cutting those off because those were like eroding through skin. I never had that problem, and I don't do that, but I don't know if that's like a part of your practice.
I never had that issue. I don't like manipulating the port in any way. I don't manipulate the port other than cutting the catheter. So no, I've never done that. And again, knock on wood, I've never had any issues with those eroding through on any ports that I've placed or seen, or that specific type of port. So last thing is, 9 times out of 10, the ports are ready to use immediately. Same with you. A lot of times they ask us to leave them access because they're going to get, some sort of infusion. I'm just careful when I place that Huber needle when it's a fresh incision. I just stay away from the glue. I'll put the glue down first, let it dry, and then access it afterwards because I just want to make sure it doesn't upset the incision. What about you?
I never leave them accessed. Okay. I think that
you just tell them to access.
Whenever they get to there. I mean, not that we couldn't, but I don't know. Just don't.
Well, sometimes it's an inpatient and they're going back to the floor and they're like, oh, we're gonna just leave Huber needle in.
So that's probably a better discussion that I wanted to bring up. Like, how many of these do you put on inpatients? I never put them in as inpatients.
There's a hospital that I work at where they it's a lot of cancer patients, and they a lot of times they're getting the whole workup while they're there, and they will place them while they're inpatient, which I actually appreciate. Having had a family member going through cancer right now, is I now appreciate them getting as much possible done while they're in the hospital, because the outpatient, there's so much delay in care in the outpatient world right now. And so I have no problem with taking care of stuff while they're inpatient. Some people are like, no, send them out and we'll take care of it, as an outpatient. But I think that, it can delay their care. And so I'd rather just get it done. And so, long answer to your question is, I do a decent amount of inpatient ports.
That's fair.
At one hospital.
Hospital. I would say like our workflow is very much like if they need, I guess if it were like a pure onc patient that they truly just needed it for, like if they were going to initiate chemotherapy in-house. But a lot of times, like it's not very common for us to get an admit to complete like an oncology workup. And so a lot of times, like they really do need venous access. And what's more appropriate is like for our patient population, I'll put in a PIC, bridge them to that port as an outpatient, and then put it as an outpatient.
As long as they have access to get what they need, you know what I mean?
Yeah.
Because it's frustrating when they're outpatient, they're trying to rush and get stuff done, and they can't get they have poor venous access, and in terms of peripheral access, their veins are already shot for whatever reason. So Okay, and then let's just talk quick about potential complications. Obviously, the follow up is whenever they're done with their treatment. It's always a happy day to take some of these port out. They're usually really happy to get it out, and I like that. That and taking out IVC filters are two really satisfying things. I just the patients are always happy those days.
I certainly like the more exciting for the patient or the port removals, but I feel like most of my IVC filter patients, like they neither care nor really know that their filter is in there. Like it's few and far patients that understand that they really want to get it out. For the most part, like taking out that port is it's an emotional milestone that's marked by the removal of the port. Totally. that is kind of it has some gravity to the situation, and like I also like play into that, like whenever I consenting them pre-procedurally, I congratulate them and make a thing of it, because it is a big deal for them, and we should be making a big deal of it. Taking out the port's awesome.
Yeah, no, you're right. I guess the filter is more satisfying.
Oh yeah, for sure. The filter retrieval like totally belongs to like the IR ego for sure.
All right, so just real quick before we finish up, how about potential complications? Obviously, we talked a decent amount about infection. Real quick, what do you give an antibiotic?
So no, I do not give an antibiotic. Do you give an antibiotic?
Okay. It just depends on the hospital protocol. I don't, a lot of times they have it as part of their protocol, and so if it is, I'll just say sure. If they've already.
And it's like a gram of Ansef or 2 grams of Ansef.
Yeah, it's a gram of Ansef. Yeah.
No, I don't think you should be too worried about giving a gram of Ansef. So what if they have a penicillin allergy? Yeah. Will you still, what do you give?
Clinda.
Okay.
Yeah. Yeah.
Yeah, so the recommendations are routine prophylaxis recommended, no, from the SAR guidelines. First choice antibiotic, no consensus. Suggested regimens, 1 to 2 grams Ansef, IV. And then comments, vancomycin recommended for penicillin allergic patients.
Okay. Yeah. All right. I stand corrected. All right.
I mean, you're really just trying to cover that skin flora and then, also treat what's in between our ears rather than maybe what's on the patient's skin surface, which is fine too.
Yeah.
I mean, I think like giving a gram or 2 of Ansef is, I don't think like if you think that's the right way to go, like I don't argue with anyone for that kind of stuff.
Right. Again, it's a lot of times it's hot. If it's part of the hospital protocol, I'm not kind of creating waves or anything like that. And then, so we talked about infection. Knock on wood, rarely happens, but it can happen. We could talk real quick about what happens if that patient calls 5 days later and they got a fever, or
actually, what I want to. So, like, I think one of the other things that can happen is hematoma. And so you can have a hematoma with your reservoir site. I've never had one at my venous access site. I think the key to that is just like clean venous access. But as far as the port reservoir, I know some operators that do this, they'll have like a little bovie on the field. I never do mine with a bovie. I don't know if you do. I don't know if that makes it better or worse, but sometimes I'll use lido with epi, which I use a lot of lidocaine, so it reduces how much is like soaked up in the system. But I just do lido with epi, and then I think like having also a tight pocket doesn't create like as much of a reservoir for that blood to pool. But I just like hold pressure really on it. I don't know. I don't have any better ideas than that.
Yeah, lido with epi is usually what I use. Again, knocking on wood, other than that case with the patient who was on Plavix when I was a fellow, I haven't really had any issues with hematomas forming. If it happened like days later, I would probably just have them take a course of antibiotics and then do warm compresses over the area, and that I don't know, but I guess I haven't had any cases of that.
Yeah, so that seems like a smart thing to do. So like you could have, I think like you can have arrhythmias with ports, in which case like. I think like it's good to know going in, like whenever you're trying to go from atrium to IVC, if you have someone who's very sensitive to arrhythmias, I'm less likely to land that port long. Like my landing zone, I don't know about you, is usually high right atrium. Like, so I think I leave a little bit more catheter inside patients than most. That's my bias. But if for some reason, like if I was like going into the IVC and I noticed that like they were really sensitive to arrhythmias, then I might think to leave that like slightly shorter at the cavoatrial junction. I think that we've probably seen like fractured ports and ports that crack, but I think that's like in the subclavian population. Fibrin sheaths are super common. I think it's just good to keep them flushed. Whenever you see a port, this is one of my favorite tricks. Whenever you see a port that flips into the azygos, like I've had ports referred to me for that. Like, what do you do to get that port out?
You can try flushing it really hard.
I think that's what I like about it. Like I just like flush it with like a 1 or a 3 cc medallion, like really hard, and it just knocks it back out.
Yeah.
I think it's still always prone to flipping, and we probably don't realize how often it's in the azygos, but every now and then, like someone gets stuck kind of in the azygos.
Yeah. Well, it was a very thorough discussion of Mediports and port placement. Thank you, Chris, for coming on. And to our listeners, thank you for listening. If you're a new listener, thanks for tuning in. Please click subscribe on whatever platform you're listening on. Also, check us out on YouTube. We have some of our podcasts are in video format. And also, please, rate and review us on iTunes. That always helps. And until next time.
All right. Thanks, Eric.
Thanks, Chris.